Hi, good morning, everyone. We are just awaiting for Dr. Kundan Ingle to join in. Hello, sir. Good morning. Snehal here.
Hello, good morning. Good morning. Can you hear me?
Yeah, pretty much audible enough.
Yeah. Is there any background noise from my side?
No, sir.
Okay. Dr. Surya Kumar, can you call few people?
Good morning.
Good morning.
Yeah,
फोन करायचा आहे का कोणाला म्हणजे we can start the meeting.
we are already informed everyone regarding this
अच्छा.
clinical meet.
Okay. ठीक.
खंदारे सर,
हो बोला की मॅडम.
आपण उरलेल्यांना फोन करायचं का?
आता कोण राहिले आहेत तिथे काय नाव करूया का? दुसऱ्या नंबरवरनं करावं लागेल. बा करतो मी. तुम्ही कुणाला करताय का? स्नेहांजली जॉईन नाही झाली वाटतं अजून.
स्नेहांजली आणि प्रियांकाला करते.
मी त्या अरुण पाटील सरांना आणि खडे सरांना करतो तोपर्यंत.
येस येस.
हॅलो हॅलो. सर जॉईन. हॅलो.
आय थिंक 10:15 झालेत. चालू करूया आपण. तसं लोक जॉईन करतील.
हा बघा तुमचं सुरू झालं. ते थांब. बस
ही वर्षाला ओळखतो ना मी. तुमच्याकडे होती.
अरे ही आहे.
अरे कॅमेरा नका करू लवकर मॅडम. तुमचं हे येत आहे.
Dr. Kundan, shall we start now?
Yes, we can start. करूया चालू. My suggestion to all is if you can on your video, I can see you, identify you, and I will be able to know you properly. Yeah, thank you. So, good morning, everybody. We thought of that little clinical background meeting for our further course. I think will be really helpful. On behalf of USPIR, I'm thankful to all the team, Mayura also, for giving this opportunity to discuss with all of you. Now, important points are a few because very soon we are going to start our clinical work. But how to prepare a patient, how to follow the history pattern, all those I thought maybe let's discuss with all of you so that we are on the same page. It becomes very easy for me to when you share your patients data, it is on a uniform pattern. It becomes very easy for me to understand and further guide you. So I thought of having one kind of clinical history sheet. If you can see, can you see my slide, my screen? Hello, screen this time, Aji. Can you, can anybody respond?
Yes, sir, it is pretty clear.
Yeah, okay. So, okay, 1 minute. Yeah, okay. So, as you see on the screen, the history sheet has got similar following points, but I think little pattern is different, but that's fine. But points are going to be same. So after the initial introduction of patient's name, husband's name, address, both their age, about occupation details, married life, duration of marriage, and some email and phone numbers. Yeah, this you should have because many times we will we will need that we need to contact them. We must have their all the contact details. Now, important about the past medical history are especially for her. This is the first about the wife's past history. We must know and ask leading questions like whether she had any history of tuberculosis, whether she had any history of hypothyroidism, is she on any thyronome or thyroxine supplementation, is she diagnosed with diabetes now? Like you can look into this factor. So she is a known case of hyperlipidemia and taking this one particular tablet, we mentioned that name. Then she is a known case of hypothyroidism. So what thyroxine supplementation dose she is on, and also she was recently diagnosed diabetes since how many months and what medicine she is taking. Then she had kind of a history of surgical, means you should ask for any surgical, so specifically related to uterus, ovary, pelvic organs or any breast, you must mention, like here it is mentioned there was history of abscess 2 times, like in right breast, and even there was some abdomen, some kind of abscess. So obviously it correlates with abscess, and diabetes goes hand in hand. So that is the important history. You should mention it in the past history. About family history, specifically, it is the diabetes which is what we want for to elicit from parents, because we know that parents who are diabetic, their children are inherited with insulin resistance. So we can screen those patients who's got a family history of diabetes. Then in obstetric history, when you note it down, if she's a primary subfertility, it will be mentioned as a nulli gravida. But if it is a secondary subfertility, then we must mention about the previous pregnancies, whether it is a outcome was a living child, what was it, what is the age, how was the delivery, whether it was a spontaneous or ART conception. Then suppose if it is a miscarriage, then we have to make a note whether it was a non-viable pregnancy which was terminated, whether it was a viable and then had a miss abortion, or whether it was a second trimester abortion. So please mention that all details. If there are any POC for karyotype report, you must mention it here. So write down properly one by one here, like what we normally write G1, G2 or P1, P2, A1, like that. Uh, Menstrual history, yes, regularity is very important. We must note it down that any cycle which is more than 35 days, it is more likely going to be anovulatory. 32, 33, 34 cycles are usually associated with little delayed ovulation, like 18, 19th or 20th day, and that's why those cycles are little late. But anything more than 35 days is an unovulatory cycle. So here itself, noting down those duration properly will immediately let you know whether patient is suffering with ovulatory dysfunction or no. Important point about how many days she's bleeding, but patient will say, yeah, normally 2 3 days, 4 days. No, like not like that, very specific. So when you write, when she says that I have a 2 days good flow, third day it is a very significantly less, almost in the form of spotting. So we will mention it here as a 2 to 3. So that is very important, because uh, there you can pick up, is there any endometrial disease in this patient or endometrial problem. Like for example, patient who's got a T-shaped cavity, who's got a very low volume cavity, patient who's got a thin endometrium, patient whose endometrial blood flow is compromised, they'll typically give you this kind of history that they are bleeding 1 2 or maximum 3 days only, and ideal menstruation time period is 4 to 5 days. So here itself you can pick up a clue of endometrial disease and keep it in mind and look for particular things. Third important point is a dysmenorrhea, and I think that is something we should mention, whether the dysmenorrhea which needs NSAIDs to control the pain. I think that is very important, because that is the patient who needs NSAIDs or injectables to control her dysmenorrhea are the more likely patients associated with endometriosis. So you can pick up that diagnosis and specifically direct your investigations. So that's like last menstrual period, he will mention it here. Now the next page, which is previous surgeries, and specifically here related to fertility, is laparoscopy and hysteroscopy. You must note down little in detail what was the positive findings. You may not write what is normal, but positive findings, especially about the tubal patency, if there are any tubal caliber problem, if there are any fibroid operated, PCO drilling done, endometriotic fulguration done, so or if there is any adnexal mass or ovarian cyst removal. So please mention it into this laparoscopy segment. Then in hysteroscopy, if there is a possibility that you can I'm sorry, where is my view? Where's my sorry, I lost my. Okay, can you see? Huh? During hysteroscopy, many times fertility patients has undergone 3, 4, 5 times hysteroscopy. So no problem. You mention it as the which month and year it was done and what was the finding. So quite a few times, sometimes there are diagrams which has been drawn by the surgeon. So it's better that we also draw the diagram here. It will help us to find out whether is there any low volume cavity. Again, when you write down HSG report, try and draw cavity picture, so because that I can pick up from those that which cavity needs endometrial correction, maybe lateral metroplasty, is it needed, not needed. So that I can pick up from HSG, and you will be able to always get that help. You can it is easy for you to explain patient that how is her cavity also. Then comes previous investigation, and that is for a wife. So you note the investigation in a specific like a time, I mean the date and the investigation report. You may not write, for example, the range, but you can specifically about what investigation we should note it down. Even if they are repeatedly, doesn't matter. With the date, you can mention those. So all four important investigations of endocrine, that is FSH, LH, TSH, prolactin, then AMH if there is any, HbA1c if there is any, and specifically about in case if there is any kind of endometrial TB PCR biopsy done, or those also you can mention it here. If there is any hypothyroidism patient, multiple reports of, so seeing at multiple reports, sometimes you get to know that how she's doing in control of thyroid status, whether it was uncontrolled, whether it is properly controlled, whether it's fixed dose, it is normal for over 2, 3 years. So all those evaluation you can do it. So try and make a note of almost all investigation which are relatedly important for fertility. You can mention it here in this slot. Then there are husband investigations. Similarly, we must write blood group about her. Similarly, if there are any hormonal assays done, especially glucose, especially FSH, LH, TSH, and if there are any GTT or blood sugar reports, you must mention, because that's diabetes is quite common in this group of patients. So make a note of it. In husband's history, three important points are there. One is habits. So if there are any habits of alcohol, smoking, tobacco, you can click it. You can mention the frequency. 1 or 2 times in a month is occasional. If it is like every day, then it is like alcohol addiction is there. You can mention that way. If he or she, if he has stopped smoking, then like since how long he has stopped smoking and how long he was smoking. So all these factors are important. Again, in illness, ask for specific question that is there any specific medical history of admission for particular illness, or if there is any history of chronic illness for which he is on particularly on certain medications. If any previous surgery he has undergone, please make a note on this previous surgery and previous illness. In semen analysis, I think you need to write the date. Three important, in fact, four important points you try and note from your reports is the volume, followed by sperm count per ml, followed by grade 4, grade 3, grade 2, grade 1. As you can see it here, grade 4 75%, grade 3 10, 0.05 is grade 2, and 1 is 10. Sometimes don't mention that 75 plus 10, 85% progressive motility. No, try and see that grade 4. If you can, if you have seen in that it is mentioned in the report, please write it in the same fashion, so that it is easy for me to calculate total motile sperm count, and it will help you. You can put that habit, like what is total motile sperm count. For example, this patient right now, the example you are seeing is 2 ml and 80 million per ml. So 80 into 2 is 160 million. So in 2 ml, 160 million is the total sperm count present, okay, per 2 ml. Now, out of this 160, 75% grade 4. So if you do 81, 160, ka 75%, then probably it somewhere comes around 105%, 105 to, sorry, 105 to 110 million. So, that is your total motile sperm count, which is good, because if you have in 2 ml something like grade 4 number above 10 million, there is a good chance that we can offer her IUI, because IUI pregnancy comes when you have a post-pause more than 10 million per ml. So this is easy for you to decide on semen factor whether I should advise this patient IUI or IVF. So make a note of multiple report, doesn't matter. You can in fact multiple report helps you to understand is there any male factor on repeated examination, whether if there is any four reports and showing grade 4 motility 5%, 3%, 2%, 8% in four reports, you understand that total motile sperm count will be less. But look at it, sometimes the volume is so important that sometimes patient do have a 4 ml volume, they have 45 million count. So 4 into 45, it comes to 180 million. And if motility says 25%, it is still good, because you will have 45, 47 million sperms in the semen where you can still offer IUI. So volume, sperm count, and grade 4 motility is the most important. Next page is the previous treatment. Now it is specifically about ART treatment. So in IUI, IVF. So suppose she has undergone IUI, like in this patient, it is mentioned that January 2023, she has undergone one cycle with letrozole, which is mentioned at the end of the line. And we have to note it down whether follicle developed, whether on what day she ovulated, whether it was in the right ovary or left ovary, then endometrial thickness on the day of if you have a monitoring chart on the day when the follicle is 18 millimeter or 19 millimeter, means on the day of trigger or on the day of ovulation, how much was the endometrial thickness. So like in this patient it was showing 7.6%, but here you can see there is no follicular recruitment. So this is probably false positive thin endometrium. So like that you can mention it into this particular line. Now then comes in IVF details, you have to mention about specifically if she has undergone, they have undergone IVF, then in IVF details, you have to mention that when was the first cycle, whether it was January 2025, September 2024, okay, then which center it was done. Then try and note it down, what was the dose of stimulation, how many oocytes they got, how many mature oocytes from the total number of oocytes they got, then how many fertilized, what was the outcome on day 5, whether it was a day 3 or day 5 transfer, how many embryos transferred, and if there are staging, you mention it in the bracket. So what happens is that when you note it down for a recurrent implantation failure or recurrent IVF failure, you can, with this kind of details, it becomes easy that how was her response, whether she was hyperstimulated, she was a poor responder. Sometimes, the starting dose is started in only very less, like 150 IU, and they with 150 she got 4, and in fact the reserve is good. So probably you understand that it was a dose which was resulting into the poor site number. So all these details, once you mention it here, it is very easy for you to assess whether it was, again it is very important about the embryo quality. You if try and if it is day 3 and day 5, so it becomes easy for you to tell the patient that it was day 3 transfer. So probably we will not be able to ever assess the failure reason from the embryo side, because we don't know whether those embryos from a cleavage stage, whether they got converted into blastocyst or no, because we know embryo quality is more better delineated when embryo grows from day 3 to day 5. So and how many embryos were transferred. Then the first visit ultrasound is very important. Like in this patient, it's a 25th day, and you can look at the endometrium 6.5. Now 25th day is a kind of a luteal phase time, and we expect endometrium to be above at least 8 to 9. So it is showing that 6.5. So earlier we saw 6.5, earlier we saw 7.6. So I can put up something like, yes, probably she do have an endometrial problem. Then noted down the vascularity. So those who have a the color Doppler, try and start using color Doppler. If you do not have, send it to some good sonologists who can give you a good vascularity. So look at how many color Doppler signals you are seeing in a subendometrial region. By 3D, you must calculate the volume. Like here it is mentioned uterine cavity volume 3.73. So it has to be above 5 centimeters square, or at least minimum above 4 centimeters square. Again, it is on the lower side here in this patient 3.7. She showed multiple fibroids. So you have to mention what is the location, what type of fibroid it is, intramural, subserous, submucous, intracavitary, size of the fibroid. So becomes easy that do we need to take care of any fibroid before ART treatment. Then comes at the both the ovaries, and you must every time you do a scan, you have to calculate the antral follicular count, because 4-5 reports of antral follicular count, you get to know what is her reserve. So here in this patient, as you can see, right ovary shows 4 antral follicle, left ovary shows 2 to 3. Obviously, this is lesser number. For a woman who is um, her age was 36 age, and at 36 age, if you have 4 and 2 antral follicle, this is premature diminished ovarian reserve. And with this note, with these points, I on the left side, I usually have a habit of writing which are the important point history points. Like in this patient, we have a diminished ovarian reserve, so we mention here DOR. If there is any sperm issue, then we mention whether it is oligospermia, astenospermia, or teratospermia, or azoospermia, or even sometimes high DFI report is there, so high DFI. Then endometrium problem, yes, I do suspect endometrial problem. I said 25th day 6.5, so endometrial, thin endometrium, or if there is any less blood supply, like here only 3 to 5 color Doppler. So I should mention it here that it is a thin endometrium along with poor blood flow. If it is anovulatory cycle, then here you can mention as a anovulation. So chart it down, summarize the things. Then suppose like endometrium, and if there is any endometriosis, then also you can, like in previous laparoscopy, it was noted that it was an endometriosis case, so you can mention it here. So next time when you look at the investigation which you have advised, you can quickly correlate with what important factors in this I have to pay attention. Like for example, in this patient, she has not undergone IUI or laparoscopy or HAG. So I mention it here, question mark tube. Means I don't know, I need to investigate. So those factors about which we do not have any information, we put it as a question mark, and yes, then it reminds you every time that okay, I have to look for it. And then final treatment, like looking at this report here, ovarian reserve, sperm and endometrium, my first advice to this patient is to get her AMH done, because it's a poor responder patient. Then she's a known case of hypothyroidism. The last report was almost 8 months older. So fresh report with TSH and only free T4. Then analysis, because that was only one report, and I want to know whether, because that is done from pathology lab. Pathology lab do not have a macular chamber, so better to do a macular chamber evaluation of semen so that you don't miss out any kind of low total motile sperm count. I can see the thickness low and the blood flow low. So this is very important, as you must know into our group, because this is something which I will always advise you to do it, and that's called estrogen challenge test, where what I suggest is that you can start giving estrogen to the patient right from the second day. So how do you give it? It is like you give first 2 milligram twice a day for 3 days. So menses second, third and fourth day, 3 days, you're going to ask her to take BD dose. Then from fifth day, again fifth, sixth, seventh. So next 3 days you will give 1 TDS. So what you have done from BD to TDS, 1 dose has been increased. Then next further 3 days, that is 8, 9, 10th day, 1, 1, 2 means 1 in the morning, 1 in the afternoon and 2 in the night. So now 4 tablets. So I have increased 1 more dose. Then next 3 days it is 1, 2, 2, and then last 3 days is 2, 2, 2. So your third day of the 2, 2, 2 schedule, that is 16th day of menses, you ask the patient to come back and you do a normal 2D transvaginal scan along with color Doppler and then 3D TVS. So that all during this day you get all information about endometrial thickness, assessment of endometrial blood flow as well as the cavity volume. So you get to know what is the status. Now why it is important, because we know in IUI and IVF we can't do any implantation, and our natural or spontaneous implantation depends on the embryo quality and your endometrial thickness. So 50% of your success depends on this evaluation. So that is there any correction needed for this patient, which we can plan hysteroscopy for her before IVF? So, like in this patient, I have mentioned down. Next step is weight reduction because she was obese, and hysteroscopic lateral metroplasty is something. Now, whether myomectomy was to be done or no, again, if you look at it's all intramural, subserous, broad ligament, fundal fibroid, not submucosal or intracavitary. So, no myomectomy is required. Only hysteroscopic lateral metroplasty I will be going ahead, and that should be the plan. So, you mention it in your plan that what we need to do it and what is our plan to do it in this case, and then it is written like do oblique own, means after the AMH we will discuss with the patient that what is the possibility of getting a good embryo from their own oocytes. Like for example, in this case, if AMH comes above 0.5, that is 0.9 or 0.8, which I will expect to correspond to this antral follicular count of 6 to 7. So if that is there, I can push that patient because she's not very old patient, like more than 40 years old, where I can push the patient for going ahead with her own ovarian stimulation. You can, in the first visit, you can tell them that, okay, if she needs IVF, then this patient, how many oocytes she will give me. Like if antral follicular count is 6 to 7, surely I will get at least 3 or 4 mature oocytes. So that gives you confidence. Also, you can give patient confidence that these many mature eggs. The only thing is that we need to tell them that yes, the numbers we can predict, but quality we cannot predict. So it's important here. If the and depending on the affordability, also sometimes we can advise patient or let them decide whether they wants to improve their chances by undergoing donor oocyte. So this is written as a DO oblique own, means this is yet to be discussed with the patient, and then accordingly IVF we will do it. So this is how you will plan your history taking. Now important markers for your, I will stop this sharing part, and so it is very important for all of us to understand that how to select your patient. So typically, if you have only anovulatory patients, or if you have a thin endometrium patient, or if you have a kind of a borderline sperm count and motility, you can put the patient for IUI. But especially any tubal problem with lot of IUI failures or planned relation cycle failures, or specifically if there is oligosteroteratosis, I think you can safely you can select those patients for IVF. Low reserve patients like one which we saw just now. So all these patients should go for IVF. That is how you will select. Especially look for in previous laparoscopy report whether tubo-ovarian adhesions, because that will lead to interference into tubo-ovarian relation. So all these things you can make a note of it. A patient who has already undergone IVF and twice or thrice failed, more likely she's going to have either an embryo problem or endometrial problem, and try and correct it, and then you can go for again the decision of IUI IVF depending on only two factors. So look at the sperm factor, look at the reserve factor, look at the tubal factor, and these are the three factors. And if there are any pelvic adhesions which alter tubo-ovarian, I think these are the cases where you can put them for IVF and guide them for IVF. Even after more than 3 IUI cycles or 3 minimum IUI cycles failure, you can advise them to undergo IVF. But pre-IVF is something what I want all of you to learn, that the endometrial factor, which is into our hand before IVF, before starting IVF, we need to evaluate our endometrium factor. We can correct the endometrium factor by doing hysteroscopies, some kind of operative hysteroscopies, and it will help us to improve the results. So compulsorily 3 points: estrogen challenge test and assessment of endometrial thickness, blood flow, and cavity volume by 2D TVS, color Doppler, as well as from by 3D will be very helpful. Sometimes patients do have a regular cycle, so probably you do not need to give estrogen to her. So in that case, you can assess it like 30-day cycle. You can call her on 15th or 16th day, which is probably the most important day of ovulation, and you can assess the thickness and blood flow and the volume. So try and make a note. If you have a 3D picture, you draw the picture, and so that try and draw exact picture of the what you see on 3D, because it becomes very easy for me to sit away from you but can guide you that okay, this patient needs to undergo hysteroscopic metroplasty before IVF. And I am more in kind of in favor of hysteroscopic metroplasties prior to IVF in lot of patients, because two important points. Sometimes patients do have a altered endometrium receptivity, which you cannot measure it by any means. But by doing metroplasties, you are actually allowing, a lot of inflammation to generate, which will allow improve the kind of inflammatory response in the endometrium, and it improves the endometrium receptivity. Plus, it's an opportunity for you to check the endometrial cavity, thin flimsy adhesions, polyps, multiple polyposis. So all those you can pick it up, and those are important reasons which can fail us sometimes. So it's an opportunity for you to look at the cavity prior to IVF to optimize your result. So if you can assess the cavity and endometrium properly, and you make sure that the endometrium is above. See, for example, if somebody's endometrium is 8 millimeter, why I should be happy about it? I know that with 8 millimeter there is a good average pregnancy rate, but if a patient we can bring it this 8 millimeter endometrium to beyond 9 millimeter by corrections, I think it will give her a very high chance, maximum chance in fact, to get a pregnancy in the first cycle. So it is important that how much normality we can achieve it prior to IVF, because our 50% success rate of IVF depends on your endometrium. So if we can correct it and we make sure that we have a good endometrial thickness and blood flow, the 50% success of IVF or IVI, we especially in IVF, it is 50% can be achieved beforehand before we start IVF treatment. But embryo quality, yes, I think one more strategy which I will suggest you, that to give to embryo quality depends on what quality of the sperm as well as what quality of oocytes we are getting. And lot of patients do have a oxidative stress, which again as a clinician we cannot assess it. So it is always better that you put the patients on antioxidants medicines. Now when it comes to male infertility, male antioxidants combination, then select a combination which will have L-carnitine, astaxanthin, coenzyme CoQ. Then see for whether that combination has a lycopene, zinc and selenium, and vitamin C. So if majority antioxidants may not have vitamin C, so you can give vitamin C separately. You can give vitamin E separately. But these are the good antioxidants combination for male infertility. As soon as you get the patient, you can start them on, so that you know which patient are for IVF. So you can ask them to start antioxidants sooner, so that in our pre-IVF workup, which will go on for next 2 months, 2 cycles, patient is also taking a antioxidant combination. So again, for female antioxidant combination, you have to look for astaxanthin is one of the good antioxidant. Melatonin is a good antioxidant. Then go for coenzyme Q, which you can go separately, because many antioxidant combination they have only 100 microgram 100 milligram of coenzyme, and we want to give 300. We want to use in all patients 300 milligram of coenzyme Q. So you can give separately if the combination is not giving that much dose. But as I said, astaxanthin, melatonin, coenzyme Q, folic acid, methylcobalamin, not minoxidil, but if it is a poor responder patient, then give them DHEA, which is a testosterone gel. Is now T transfer trial has absolute given clear evidence that gel is not sufficient, but still some evidence is still in favor of DHEA. So give DHEA to the patient for 2.5 months if she is a poor responder. So this is a good combination which you can give. If your combination do not have this, give separately. So, but give that, it is very important. So start antioxidants for all your IVF patients. It will help. See, it's a very simple thing. If you have 100 patients who are undergoing IVF, and see 30% patient are going to give me a bad oocyte or bad sperms, which is going to affect their embryo quality and add into my failure. At least giving antioxidants to my all 100 patient will help me to prevent that 30 failures because of the bad embryo quality. So that something which we need to understand. Especially PCO patients. If you have a PCO patients undergoing IVF, you must ask for 2 hours 75-gram GTT, because we want to rule out a patient having insulin resistance and actual diabetes. 20% PCOS are having diabetes, which you can pick it up majority times when you ask. These patients are diagnosed when you do a GTT, and till that time patient is not aware that he or she is a diabetic. So GTT is a good investigation. I will suggest you to put all our IVF patients, especially for those who, sorry, all PCO patients who are undergoing IVF, on a combination of metformin along with myoinositol and dichloroinositol. All patients should be on BD doses. Like commonly, the Met PCO Care or Ushorem, they are good, brand names which you can put it, and give them a twice a day continuously for over 2 cycles, like, and along with antioxidants, or as soon as you get those GTT reports within few weeks. So start them on this medication. We have to give for at least 60-70 days prior to our ovarian stimulation for IVF. So these drugs, should be your pre-IVF adjuvants, where a patient should have taken, so that we don't lose time. Sometimes, we haven't started, we finished our histoscopy workup, and then we realize, oh, there was no antioxidant. Again, 2 months are going to go. So try and avoid this kind of scenario, and use antioxidants for at least 2 to 2.5 months. So that is very, very important. Okay, so with this, once it is done, then comes the ovarian stimulation. Now majority of our ovarian stimulation, we don't need to use recombinant FSH, because it is too much financial burden. Your HMG is going to be sufficient. Make 3 categories of your patients. One is a normal responders, hyper responders, and poor responders. Identify looking at their antral follicular count. Anybody who can give more than 15 oocytes is a hyper responder patient. Anybody who will give 8 to 15 oocytes will are normal responders. Anybody will give more, less than 7, less than 6 or 7 are the poor responders. So only for poor responders, and especially elderly poor responder, are the one who will go for ovarian stimulation with recombinant FSH, along with later adding HMG or maybe recombinant LH, or combination of recombinant FSH and recombinant LH. So I don't want to confuse you. Select a elderly poor responder, and only that patient will be given recombinant FSH. So because recombinant FSH is a costly drug, becomes a burden on your patient. The same number of oocytes with the same quality, you can get it with HMG. You need a LH, which is present into your highly purified HMG, urinary HMG. I think that is something which we will follow it for ovarian stimulation for our patients. So HMGs, once you have a patient, and when we are going to start, we will guide you which kind of brands you can use it. So, but HMG is something going to be our major concern. All poor responders, and especially the normal responders, where we do not expect more than 15 oocytes, we can go for a dual trigger here when you want to give dual trigger for IVF. And here we will use always and always recombinant SCG for all our patients, because we know that the consistency is there. There is no batch to batch variability. So we are going to use recombinant SCG for almost all our patients wherever we are using SCG. And when it comes to dual trigger, we have to give this 250 microgram of recombinant SCG along with 1 milligram of leuprolide, or if you are using decapeptyl, then 0.1 milligram PFS, one single syringe. So that combination is a dual trigger. Suppose patient is a hyper responder, we don't want to use SCG, we can only give GnRH agonist. So GnRH agonist trigger, when it comes to leuprolide, it has to be 2 milligram dose. So when you have preparation having leuprolide 4, that is 4 milligram per 4 ml, out of that 2 ml we will use and give it subcutaneously, that becomes a 2 milligram trigger dose. If you are using a decapeptyl, decapeptyl is available only as a PFS, as a 0.1 milligram PFS. So we will use two syringes, that is 0.2 milligram. So that is your agonist trigger, especially in hyper responders or any patient who's got more than 15 follicles. We are not going to give SCG because we don't want even moderate hyperstimulation to manage later. And then we plan our USI to travel, during which time I will be there. During our first or two batches, I want you to attend and come there during our batches, whatever cycles we do, because we are going to discuss this also. Your problems which you are going to face it in your practice, common problems, we will sort it out. And also again to streamline and fine tune our evaluation and our pre-IVF workup. So I think Dr. Surya Kumar, I think I have shared with him that estrogen challenge test prescription he will share in the group, and you can just go through it once, which I have told you, and that way you can start evaluation. Now, this is very important, but at least before we start 2 months prior, we should select our patients and start doing their workup so that when we launch our center, when we are going to soon launch our center, so that time our patients are already ready and we are ready to go ahead with our IVF first batch with at least 3 4 patients or 5 patients in first batch, so that it's a win-win situation for everybody. Okay, so that is very important, and this is what I wanted you to understand. uh, with this kind of introduction, I want you to come up with your doubts. Please don't hesitate to discuss. This is our close group. Remember, not any doubt in your mind. Do not consider that how I will ask. There is no need. We want to hear, grow, and become a good fertility clinicians. Most important, you have patient comes to you as a fertility specialist, and once you deliver the patient, I think you are the one who gets most satisfaction. Patient is always happy with you, but you are the one you feel that okay, we have done something for our patient. So do not think about asking questions, smallest doubts, sort it out. This is our close group, and there is nothing feeling inferiority. Okay, so the more we discuss, the more we ask questions, we are going to become more and more expert. And this is what I want you to, in during our association, that we should be frank enough. Like I remember some time back, one of you has sent a patient because the center was so we did, and she's pregnant today, and that kind of so smallest doubt we discussed and we followed it up and we got a pregnancy in the first attempt. So in fact, I want you to, I'm absolutely okay to call me at any time. You can message me, you can directly call me. I'll pick up the phone, give you that, immediate response so that it becomes easy for you to, this. Again, the way I have put it, the evaluation part, the history sheet. If you have put in the history sheet, take a photograph and send it to me. Very easy for me to quickly tell you what is the plan. I can tell you the plan also in the first attempt. Okay, so in the first phone call only. So if that's why I wanted you to follow that history sheet pattern, which even I think your 2 days back meeting had happened, and probably those things have been discussed about writing a history in a particular manner. So if I want you to ask questions if you have something in your mind, may not be for clinical side, but something about how to go ahead with coordinate IVF and all that. We can discuss that furthermore. But this is something which I wanted you to follow the pattern, our plan, so that we are on the same page. I always tell my colleagues who comes to me for training, see, this is where we were always at the time of PG. It takes this many years to reach at this stage. Now, never for you to, when you begin fertility, don't go back here. Okay, start from here further onwards. So that's how, we need to learn fertility science. So try and correlate. The more you pay, now the more patients you will manage, you will understand that there is not much variability in the management. The management is very simple. Okay, we have to make the things very simpler for the patient. So protocols are set. We don't need to now discuss, why we are not using recombinant and why we have to use the recombinant LH. The things have been evidence based are set. We just have to follow it, and the success is on our way. So we can safely get with frozen embryo transfer protocols at least 70 to 73% pregnancy rates in the first attempt. So this is what. Any questions? You can please feel free to ask. Unmute yourself and please ask the question. I can't hear you.
We'll start with Dr. Khandari.
Yes, Surya Kumar, you. We can't hear. I can't hear you. I don't know what is the problem. I can't hear you. Mayura, I'm not able to hear anybody. Can somebody speak so that I can understand other people that whether is there any
Hello,
problem
sir.
with
Good
it?
morning.
Yeah, hi, good morning. Yes, I
Can
think
you?
I can
Yeah.
hear, but I am not able to hear Surya Kumar when he's speaking. Okay, any,
Network issue from his end, sir.
sorry?
I think there's some network glitch from his end.
Okay. Any questions, any doubts, any more to discuss?
No, just I have one question. We are
Hmm.
planning batch IVF.
Yes.
Probably before opening, as Madhur sir said, ki we should have
Hmm.
small five patients batch, at least
Yes.
two batch IVF. Okay. So how we select the patient for first time we are doing this batch IVF? So
Yes.
selection of patient as like we will get more success rate initially, so that will
Yes.
build up our
Yes. So
confidence.
now a very important question: how to batch them and how to select for the batch. So remember, there are ways to schedule your transfers or pickup dates. So there are methods of scheduling. Like we are going to use OC pills, we are going to use estrogens, we are going to use progesterone for scheduling to adjust the dates so that we get the patient's periods on one day. So what I suggest is we have to make one person who is a central coordinator, like maybe Dr. Surya Kumar Khandare. So once you have the patient, give a details to him so that when it comes to plan a batch IVF, the first batch, we need to know their recent LMP and accordingly we will adjust with these kind of three molecules, OC pills, maybe estrogen or progesterone. So simple. Suppose a patient who's got a menses. Suppose you know that the day of pickup is fixed. So we have to go 11 days back. For example, if the pickup date is 16th of August, then our stimulation should start by 5th or 6th August. So at least 10 to 11 days of stimulation we want to have. So patient's periods to fall on 5th of August. So that 6th we can start stimulation, 16 we do a pickup. So get the periods on 5th, any progesterone or ocipils which we have given, we have to give 4 days, we have to end 4 days prior. So if you want on 5th August period, then up to 1st August we are going to give them a progesterone and ocipils. Now once we know this, that 5th August should be the period date, now we have to see in July if a patient has got a periods probably before 25th, okay, I mean not even before 15th of July, so only 15 days we have or 20 days we have. Such patient, as soon as they get period in July, we put them on OC pills. So 15 days minimum or 20 days we can give it, and then we can withdraw on for 2nd August so that she gets her period on 5th August. So that way patient can be managed and get her menses in even in a shorter time. Now sometimes patients periods were falling on 20th July, we want on 5th August, but we can delay this. So we can delay with the help of progesterone. So if the patient's expected menses on 20th July, we start giving her progesterone 5 days earlier, so that 16th July I put her on progesterone, give it till 1st August, 15 days I'll give her progesterone and withdraw on 2nd, so that she'll get her withdrawal period on 4th or 5th. Again, that's fine. So you can get the menses in 15-20 days with OC pills. You can delay the menses with progesterones, maximum 10 to 12 days. Suppose patient's periods are falling within weeks time of your expected date, means suppose 5th of August is our expected menstrual date for this batch. If the patient's natural menses are expected to be between 28th of July to 5th of August, let it come. From the second day, we add estrogen to her, 2 milligram twice a day, and we continue till 4th. Fifth, we stop estrogen, and fifth, we start stimulation the very next day. So suppose 28 जुलै 28 जुलैला पिरियड आला पेशंटला, 29 जुलैला आपण इस्ट्रोजन चालू केलं आणि तिला 4 पर्यंत दिलं. So that estrogen do not allow endogenous FSH to release. So there won't be any follicular recruitment. So that estrogen will downregulate the pituitary for FSH. So FSH downregulate होणार. 4 तारखेपर्यंत दिलं, 5ला सकाळी बंद केलं आणि 5ला डायरेक्टली स्टिम्युलेशन चालू केलं. So now ovary will respond to your exogenous HMG. Okay, so depending on your dose, you will have a recruitment of the follicles. So असं आपण we are going to use 3 molecules: OC pills, progesterone and estrogen. आणखी काही सिनारिओ आहे, क्लिनिकल क्वेश्चन्स आहेत? Aparna, your voice is breaking. I can't hear
Can you hear
you.
me?
Now, yes.
Okay. I have few questions ready over here. So now
Okay.
today is 10th of August.
Hmm.
Now for the first batch to start, now we have to inform the cases whoever patients whoever we have. So when if we are if we are planning to do it in October, I think. Yes, Snehanjali. First in October we want to do the first batch.
First batch.
So this
Right.
planning for that.
So,
When we will call the patient.
suppose our batch is in October and today we are in August and we want to little schedule their date. So what you have to look for is that whether patients duration of menstruation is how many, whether it is regular, irregular. So you have to tell her to inform you the first day in of menses in September. Okay, sorry, in August, what is the date? Then you can calculate that when is her expected menses in September and what is our date. So, then we start manipulating the cycle from September menses. Okay, so you have to mention, ask them to inform you. Even we are not starting ART, you must know there what was her LMP in August, what was her LMP in September. So that way we can. And if we are planning in October, this is a good time to start antioxidants for your patients for IVF. Okay, put them on antioxidants right now so that they should be able to take at least 72 days prior to our oocyte retrieval. They should have taken for so much minimum duration. Giving 1 month antioxidants do not contribute anything to our gamete quality. Remember, we have to give it for 72 days.
Okay. And we should
How
plan
will,
at least 4 to 5 patients for one cycle, isn't it?
That is our first target. Now, the first batch, why we want only 3 or first batch, because we do not have a proof of embryo culture in our hand. Our equipments are first time they are starting. Our culture system is first time testing. We want to have a good batch where we don't want any problem in embryo culture. That is why we are doing only 3-4 cycles. Once we know from the first batch that we got a good blastocyst, okay, it's not on pregnancy, it is on the good quality blastocyst. If you have a good quality blastocyst from your culture system, we are not worried. Then we can push for more cases. That's not a problem. Why first batch 3 to 4? Because we do not want, see, for simple, if you have a 8 to 10 cases posted, and if there is any problem in the embryo culture or any lab equipment because it is the first time, why do you want to make suffer 10 patients together? Let us focus on only 2 or 3 or 4 patients in the first batch and make sure that the embryo culture. I am sure till now, whatever work we have done at other centers, we are not worried about embryo culture till now. We have got in every center good embryo from the first batch only. Okay, so start having first batch planning till 4 or 5 patients, and I think that should be some. Once we have that, like in Bid district, what we did is we started with a 4. This time we have 8 cases. Second batch, immediately second batch we have 8 cases. So once you have a first batch going and giving you blastocysts, we are all done. We are good.
So first, we will inform all the cases, or we'll collect all the cases history at one of the coordinator, like
Correct.
Dr. Khandare or any of the five,
Right. Right.
and we will
Right.
inform you that so and so cases. And you may whatever we are giving treatment, any changes are there, and then we have to plan for the October batch or September end batch.
No
So
problem.
when you suggest, sir, when you will be available,
See, my
when you will
working
be
day in Pune,
available for
my
the
my working time in Pune is from 10 a.m. to 6 p.m. So in fact, after 6 p.m., I'm comparatively quite free, so that we can, if you want to discuss a clinical scenario of some patient, you can call me at any time after 6 o'clock. But as I said, when stimulation starts, or suppose you have some reports which you want to discuss, patient is right in sitting in your OPD and you need to counsel the patient, please feel free to call me and discuss those points. Short calls for 3 5 minutes, 10 minutes, I don't mind receiving it at my end. Even my work is going on, please do not hesitate to call me. But if it is a clinical scenario, if any case we have to discuss for 15 20 minutes, best thing is to call me after 6 o'clock. We can discuss, and that way you can call the patient again and counsel to decide a plan or something. But I don't keep that time barrier. Please feel free. If you feel that you have noted down the history, you want to counsel right now, you can call me, give me those details. I can just go through it and tell you what kind of plan we can have it in this patient.
will you suggest us for all? Still, we have to buy all these disposables, media, and all, and we have one-to-one talk about it. Or will you suggest for us all these brands and trades? You
Your
got my
question was that can I suggest about media, which media to use and which HMG to use? Yes, I can. Yes, of course. Of course. I think we can go for this global media, which is quite all right. Okay, the global one. And that should be good media. It's a single step embryo culture media. So we can go ahead with that.
for the optimizing the results. What precautions we have to take since we
Okay,
are
the
starting
pre-IVF workup. Your pre-IVF workup is the most important. So, for example, failure comes because of the
no, not
endometrium fail.
the
Uh,
patient, not regarding the patient. That we'll discuss with you as a
mhm.
center for optimizing the results. So please tell us the steps what we have to follow. Center, sir. As it's a new batch, we all are also new.
Okay. So I think every step, please coordinate with me. That is the first thing which you need to understand. Okay. For every step, do not hesitate to call me for smallest part of your ovarian stimulation, your evaluation. That is the first thing we need to understand. The most important is the coordination between all of you and me is very important, so that we follow the same steps what is expected from you to do it as a pre-IVF for ovarian stimulation, number one. Number two is we are going to test our lab by putting a semen sample, which is process sample, like what we'll do before 3 or 4 days prior to our batch IVF. What we can do is we will take a semen sample, process it with swim up, and those grade 4 sperms which are separated in 0.5 ml of media, that tube, put it into the 6 ml tube and shift it into the incubator and keep it for 24 hours. And after 20 means, of course, you have noted down the motility prior. Then after 24 hours, you again check the motility. If there is survival of sperms more than 80%, I think your culture system is superb. There is no need to worry. So this is one way we can assess our culture system quality standardization prior to our first batch. Once we come near to our oocyte retrieval day, we will guide you which type of oocyte retrieval needles we want, what kind of things we want for the pickup and transfers. what disposables we want, which company to follow. I will give you all those details once we are close to the batch, at least 1 or 2 weeks prior to our batch. We will have again a meeting regarding this.
Thank you. Another question, sir, for USG ultrasound. We all have different USGs, sir. So, do we need the standardization or how should we?
Right. Actually, lot when you want to do IVF practice, your color Doppler plays a very important role. So your machine should have a good color Doppler or 3D. See, sometimes there are companies who's got a good machines. You have got a good high-end machine, but your color Doppler settings are not good. So call the company people, make sure that your color Doppler settings are properly calibrated. So it is easy for you. Sometimes a patient who's got a very good subendometrial blood flow, but your color Doppler settings is not picking up, or you do not have UPS in the system. So you get all false positive reports, false negative reports, and then your assessment is completely not good. So suppose our center has got a good machine like P8 or S8. So you can send it there and somebody who, or you can come there and do a sonography on that machine for your patients. So it can be done. Make a utilization of the machines wherever you have a better machines. If you do not have even machine, you can go to your colleague's place and do the scans. But scanning a patient on a standardized machine is very, very important. Now, if you do not have 3D, sometimes your machine has got a 2D and color Doppler, but you do not have a 3D. Try and see and talk to the company whether it is upgradable, because 3D is again, you need a volume probe and you just need a software into your machine. But if there is any machine which is upgradable, upgrade it to 3D. 3D is very important for us, especially for the uterine cavity volume assessment. And suppose you do not have, do not hesitate. Maybe send it to the one of the associate who has it and get it done. It is very important.
Further, how many minimum cases will be required for you people to come to Satara?
See, for
Batch
few
IVF.
centers we have done it for even 2 cases. Okay, we have come to Sata. I mean come to we have gone to the centers for just do a two pickups also. So first or two batch, I think no worry. Whatever cases we keep, we'll go ahead and do it. So don't worry about it. But at least try and keep 4 or 5 patients in your batch, so that minimum 4 or 5. Why? Because see, when you order a media, okay, forget about disposable. Disposables have got a little longer, but the problem is your medias, your oils, they have a shorter expiry. So whatever 20 ml of media we order, we at least have 4 to 5, so we can use it. We don't waste media in this, because if you have 1 or 2 cases, your rest of the media is all gone. I mean, you won't be able to use it again for the next batch, because they have got only 20 days expiry, 15 days expiry. So that's why these 4 or 5 cases are important to, have your good finances to adjust.
Will you be able to give a baseline scans and this video telling us,
Yes,
guiding us?
yes. You mean to say that how to assess, right? How to assess, right?
As
I will send it to you in the group.
video and baseline scan.
Yes, I will do it. I will send it to you. I will record it and share it with you. From tomorrow onwards, you will get those videos in the group with a running commentary, so that it becomes easy for you. That's a good idea. It's a good way of learning. Who do not do scans in details, I will share the videos. From tomorrow onwards, I will do that.
Frankly speaking, till now we were looking at the infertility cases as a gynec.
Understand?
So
Yes.
we have our own preconception.
No, that's fine. I
Probably
mean,
we may be
and
doing some wrong.
no, well, never think see, we, as per our expertise, we advise our patient. We never want patient to suffer. That is always our, as a doctor, our approach. Yes, probably we are not extensive in our evaluation. We are not offering them what should have been ideal treatment for them. We will learn. That is how we are going to learn from our own. See, I can tell you within 5 to 6 batches, 5 to 6 months, you will be able to do a good evaluation and workup of the patient, because that's how every associate has to do, select your patients and follow those cases. Then you'll understand that the protocols and uniformity in the protocol, and then it is very easy after 5 6 months. It's not difficult. You will only feel it during first or two cycles. After 6 months, it's not going to be there.
Anyone else who have questions, please ask.
I can't hear you, Dr. Surya Kumar. We are not able to hear you. I don't know what is the problem. Go to the audio setting. You're logging from the mobile, so just check from the mobile. Go to the settings more and check whether your audio microphone is volume is less. Increase it if it is microphone volume. Check microphone volume. Can't hear you.
Sir, please put questions on chat.
You can put it on the chat. I have opened the chat. Antioxidant trade number, trade name. I think that's what you want to ask. Yes. So for a kind of male infertility, I will suggest you to have. There is one combination which has got even vitamin C in it. So there is Fertilia M, Fertilia M, Ferti LIA dash M, Fertilia M. One of the brand is there. Jurifert M, again a good brand, Jurifert M. Then you can use Fertile Gold, FERTYL Fertile Gold by RX Lab. It's a good combination. You can even use Fertisure M, which is from Sun Pharma. So these are the four good brands you can use it. For female infertility, again, a Fertilia F is a good combination. Fertilia F. Then there is Dream Sure F. Dream Sure F is another good combination. You can also look for and for female fertility, especially for PCO patients. If you have, there is something called Fertile F for especially PCO patient, because it has got a myoinositol in it. So Fertile F, it's a good antioxidant for them. For poor responders, I'll give you 2 3 brands. Of course, what you look for is DHEA, melatonin. It's a good combination. So or with folic acid. So my DHEA plus, my DHEA plus is a good combination. Or Sun Pharma Ovaris is there. Ovaris. That is another brand name which you can use. For coenzyme Q300, you can go for Ultra Q300. You can use CoQ300, or you can use Certain 300. Sorry, CER-10 inside bracket 300 milligram. Certain 300. So there separately you can use it. All patients put them on these 3 combination medicine, that is methylfolate, methylcobalamin, and pyridoxine active metabolite. So you can use Folsibel, you can use Folsef, give it separately. Okay. Any other question? If you have, put them in the chat if you are not able to hear. Otherwise, you can on the video and talk to me.
Dr. Abhilasha.
If there are no questions, then can we call off the meeting?
I think no one. Yes, sir. Thank you very much, sir. Guided us a
All
lot.
right. So please feel free to contact me. I think I am there in the group. You can put the doubts in the group also. No problem. We will sort it out.
Sir. Thank you very much. Thank you all of
Thank you,
the
sir.
participants who have.
Thank you.
Thank you so much, sir. Thank you, everyone.
Okay, bye.
Bye.